It is also important to discuss a couple of other points. We all deal with patients with lung cancer who unfortunately have a lot of comorbidities when they come into our clinic. Now, this particular case, patient had a really good performance status, not a lot of different issues. But the question always comes up that at least in some places, there is a long time that it takes between obtaining a tissue. The patient is diagnosed, the patient sees a medical oncologist typically, and then molecular testing is ordered at that visit, and then it might be 3, sometimes 4 weeks, unfortunately, before we have the molecular data. So the question always becomes, well, do we wait for the molecular testing to come back, or do we just go ahead and start treatment, and which is better or not better? And I'm going to make some general comments about that, with the understanding that obviously we practice in different settings, and patients' well-being should come first above and beyond everything else. But in my view, I think no patient with metastatic lung cancer should get treatment until we know the molecular profile. And by that, I mean, at least, again, in my view, next-gen sequencing is what we should do. Yes, we need to have the PD-L1 as a potential biomarker to decide immunotherapy, chemo plus immunotherapy in the absence of targetable lesions. But I think next-gen sequencing should be done on everyone. If a patient who comes to my clinic rather asymptomatic, again, very similar to the case that we presented here, and I get the sense that waiting another week or two is not going to be harmful to the patient, then my preference, of course, with patient's agreement and full acknowledgement of patient's preferences and all that, is to wait for the molecular testing to come back, because it has significant implication as far as tolerability of treatment and responsiveness and everything else. So my preference always is wait until I have the molecular data before I sort of decide which direction I want to go to. If I see a patient who's a never smoker who comes to my clinic with metastatic lung cancer, I will try to talk to the patient about the importance of the molecular testing and waiting for the results. But if a patient is very symptomatic, then I would probably trigger treatment with chemotherapy alone without the use of immunotherapies, because of the potential increased toxicity if a patient has an EGFR mutation or an ALK translocation and requires targeted therapies. For that concern alone, again, if a patient is not symptomatic, I would wait for the testing, but if they are symptomatic, I would probably start with chemotherapy alone. If I can wait, then I'll get my results, and let's say I find a BRAF mutation, much like what we have in this case, then my preference is to start with targeted therapy because it works better, and because it is very well tolerated, and because it doesn't really have as big of an impact on the quality of life of a patient, because these are oral agents. Patients can take them at home. They are seen in the clinic periodically for toxicity assessments. They don't have to come to an infusion room hooked up to an IV every 3 weeks or so. So, I mean, there's a lot that goes into the targeted therapies that we're using from a convenience point of view, tolerability, clinical efficacy. So I think the preference always is to start with targeted therapy when the information is available. Again, I realize that it is hard for some patients to hear that they have metastatic cancer and that their doctor is not going to start treatment right away. But if we can manage to educate the patients and spend the extra time to say, these are the reasons why we think we should wait until we have the next-gen sequencing, I think it goes a long way. So again, using the clinical scenario is helpful. So never smoker, if you can wait, please wait. Somebody comes in, heavy smoker, has a lot of disease, you have to start something. You still have a possibility of having a targeted therapy. So smoking by itself does not exclude patient from targeted therapies, but you have a little bit less a likelihood. So in that patient who's in trouble, start with chemotherapy alone, wait for the molecular testing, and then decide whether you want to add the IO or you want to switch back to targeted therapy depending on the results. So at least that's the way I have been managing these patients. Since we all realize the importance of finding patients with these rare mutations, and the fact that sometimes waiting for the results of a tissue biopsy to come back could be complicated and could take several weeks, I think it's important to realize that the liquid biopsy can be a major asset in this setting. The liquid biopsy panels are easy to perform. A couple of tubes of blood sent to a specific center. And in general, based on the data that we've seen recently from multiple institutions and sources, the results of the liquid biopsy can become available a lot sooner than tissue, sometimes in a matter of a week or 10 days, which I think is potentially an important feature of the liquid biopsy that has to be emphasized. Many of these panels are really, really good at detecting some of the more common mutations that we deal with, EGFRs and BRAF and everything else. So I think there should be serious consideration given to obtaining liquid biopsy panels on patients who walk into our clinics. I think it's also important to realize that, again, more recent data suggests that if you do a combination of both liquid biopsy and tissue-based NGS, you can actually detect a higher percentage of patients with various mutations, meaning that both the liquid biopsy panel and the tissue biopsy could have false negative rates. Just because of the technical issues involving both testing. Therefore, at least again in my clinic, I am revising my flow such that I do obtain both liquid biopsy and tissue biopsy and send for sequencing and for detection of these mutations on majority of my patients. Again, because I think finding even another 5 to 10% of patients with both methods that could benefit from targeted therapies is important. So that's how I have decided to manage my patients, and that's how I interpret the data. So incorporating liquid biopsy into our practices could be very, very important. With all of that in mind, I think we have to come to the realization that we really have made significant progress in the management of patients with metastatic non-small cell lung cancer. Finding these driver mutations, finding the translocations that can be targeted with specific targeted therapies have been significantly important for our patients and for our practices. Patients respond really well. Their quality of life is maintained. They have better survivals, or at least better clinical outcomes to the extent that we can determine. There are more and more of these mutations that are being found that are now targetable because we have better drugs. We have drugs that penetrate the blood-brain barrier for a majority of these patients. So these are significant improvements. But these would not have been possible, and our patients would not be able to benefit from it if we don't do the testing. So again, at the expense of sounding preachy, we have to test our patients. So using liquid biopsy panels, using next-gen sequencing for tissue, streamlining the process so that the testing is reflexively done in all the centers are really, really important aspects of detecting these mutations. For patients with BRAF mutations, again, particularly V600, I think use of targeted therapies, like we have discussed in this case, is significant and can have a significant clinical impact on the lives of our patients. Yes, it comes at the cost of some toxicities that we discussed, in particular the squamous cell carcinomas of the skin that had to be managed. But nonetheless, the results suggest that if a patient is diagnosed with having a BRAF mutation, targeted therapy is the way to go, at least as the initial step in this particular process. So I would encourage you to improve the testing in your centers and try to detect these mutations and take advantage of the really great data that has been generated for the management of these patients.